we've had a lot of experience in the world of lung cancer with targeted therapies. And again, we're learning more and more about these potential targets for which we have very effective drugs. Again, case in point, for instance, an NTRK mutation that now we have very effective therapies to. So for BRAF mutation, again, we'll learn a lot from our colleagues in the melanoma world also. Starting with a single agent BRAF inhibitor was shown to be effective. But again, because of the bypass mechanisms that we briefly referred to, meaning that blockade of a specific pathway can lead to cancer cells choosing a slightly different parallel pathway for uncontrolled growth, sort of led to the discussion that perhaps dual therapy for BRAF mutation would be of importance. Again, if you think of this as a sort of a cascading signaling pathway, the way we sort of simplistically but routinely think about these pathways, so in the top of the pathway is probably RAS, followed by V600E BRAF mutation. A little bit lower down, you have MEK, and then at the bottom, sort of downstream from all of that is ERK. So if you follow this part of a signaling cascade, you'll see that inhibition of the particular growth pathway at two separate points, BRAF and MEK, it can be a bit more effective. And in fact, that is what trials have shown us as an example of the particular responses and all of that. With the combination of the dabrafenib and trametinib in patients who are previously untreated, the response rate can be as high as 64%, with a disease control rate of roughly 75%, and a median PFS of just around 11 months. So I think these are really good numbers to have for, again, fairly well-tolerated targeted therapy, as opposed to, for instance, a single-agent drug where the response rates are probably closer to about 30 to 40%, with PFS that's roughly around 5.5 to 6 months. So again, highlighting that the combination of the targeted therapies, at least in this case, does seem to be a lot more effective than single agent. And also, again, takes care of a common potential resistance mechanisms for this particular patient population. So that's why the double therapy has sort of, or the dual targeted therapy has become the standard of care. Obviously, in patients with metastatic disease, quality of life is really important, and it's something that we have to emphasize and pay attention to. So then under that category, every time we talk about treatments that we think are effective, it sort of becomes a pros and cons. So we have good responses, good progression-free survival, overall survival seems to be better, but at what cost? So what are the toxicities of these regimens? Again, as clinicians, we've become accustomed to saying, oh, these are well tolerated, but from the patient perspective, sometimes these are different. And again, the process of having a patient go through a specific treatment involves informing the patient of all the side effects like we do